Welcome to Pulmonology Read Aloud. This is Dr. Anshum, and I'm here with the second volume of the lung cancer series. And as I mentioned last time, in this video, I will be talking about biomarker testing in lung cancer and treatment modalities of non-small cell lung cancer. Now we know that almost 25% of patients with lung and bronchial cancers are now alive at the end of 5 years and more after diagnosis. And this has been possible with targeted therapy. This includes both patients with non-small cell lung cancer and patients with small cell lung cancer. And this overall survival rate, if we talk about adenocarcinoma, it can go as high as 32%. So targeted therapy or biomarker-based therapy for any cancer offers us much better advantage in terms of its success. So as pulmonologists, we must know what are the biomarkers that we test, what is the relevance, and we must also know that in such a case, what kind of therapy can be offered. So with this video, let's get started. So, as I said, non small cell lung cancer has changed from being a therapeutically nihilistic disease to that which has a lot of therapeutic options. So, there is a lot of progress and enthusiasm in management options for non small cell lung cancer. Whoever is eligible for targeted therapy must be provided the targeted therapy so that the treatment selection is appropriate and the outcomes are optimal. With 5 year survival rates going as high as 62% in non small cell lung cancer, the biomarkers become critical, especially when you're dealing with an advanced disease where it can definitely reduce the load of the cancer. So today the first paper that I will be reviewing is the NCCN Guidelines for Management of Lung Cancer and specifically non-small cell lung cancer. So according to this guideline, if a patient requires an urgent therapy, in that case, doctors can consider waiting till the immunotherapy results or the biomarker results are out and can use a platinum based chemotherapeutic regimen. But if you do have an actionable marker that you can discover before starting treatment, during the first line treatment, that should be your preferred option. If this biomarker is discovered in the first line systemic therapy, then whatever planned systemic therapy, including the maintenance therapy that you were giving earlier, that you can either interrupt or you can complete. But eventually, you would want to target the targeted therapy. So for discussing about this important biomarker, I have chosen this article from the Oncology Reviews published in 2025 by a group from Delhi who talk about a detailed review of the biomarker testing in lung cancers from bench to bedside. And they mention in their opening introductory remarks that non small cell lung cancer is a poster child of personalized medicine. And now we should be leveraging this in the disease management. So, what we have to do is to check for point mutations, insertions, deletions, alterations, fusion of genes, and instability information to be able to use such targeted therapy. The three most important routine biomarkers that are tested in non small cell lung cancers are thus EGFR, ALK, and ROS1 biomarkers. So, if you have to remember at least the main ones, then you must know that these have to be tested for alterations. There are still several other additional biomarkers that have been added to the diagnostic landscape, and I will be talking about them, reviewing this article from 2025. The current guidelines recommend testing for at least 7 biomarkers upfront at the time of non-small cell lung cancer diagnosis. So that means if we are able to have a wide range of targets and corresponding therapies, we can leverage that for good disease management. Testing for biomarkers is done using a lot of methods, which include polymerase chain reaction based methods, direct sequencing methods like Sanger sequencing, pyrosequencing, and recently the more advanced next generation sequencing or NGS or multi gene sequencing, which is also being used a lot in tuberculosis to identify the whole genome. Now, if we use an NGS kind of a testing, it does avoid performing multiple sequential single tests for all the biomarkers and has a lot of advantages because it spares the tissue samples, it avoids the delays, and it helps match the patient to the most appropriate therapy. But because of the cost, because of the slow turnaround time, and lot of other technical issues, you may not have this available at hand. So in such case, the PCR based methods and direct sequencing methods are used quite often. This is a flow diagram taken from this paper that shows the steps that are involved in NGS or next generation sequencing. So, whenever we have a patient with non small cell lung cancer, preferably adenocarcinoma, in such a patient, the NGS testing is done with the DNA and RNA panels. So, the first step here is extracting these. The second step is library preparation. The third step is bioinformatics. And the fourth step is the clinical report. So, when you isolate the DNA and the RNA fusions and other alterations, you would either see missense mutations, insertions, deletions, or splice mutations that can be identified. Of these, mostly in both DNA and RNA, you can target specifically in DNA mutations EGFR, BRAF, KRAS, MET, RET, ALK, and ROS1 mutations. In the RNA, you can target the ALK, ROS, RET, NTRK, NRG1, MET, and BRAF gene. There are also prognostic indicators, which include TP53 amongst many others, that can be utilized to associate the specific mutation and the prognosis after treatment. These are the biomarkers that are very commonly used in non-small cell lung cancer. And as I said, the guidelines say that upfront at least 7 of them should be targeted. The 2018 College of American Pathologists and Molecular Pathology Association guidelines have advocated that at least the EGFR, ALK, ROS1, and BRAF mutations are checked upfront. And we offer NGS only when sequential single gene testing yields negative results. But there are certain societies like the Spanish Society of Medical Oncology that upfront asks for panel-based testing of most of these biomarkers. Now, amongst these, when we talk about the EGFR biomarker, we know that the drugs that work well in such mutations include gefitinib, erlotinib, afatinib, and osimertinib. How we test it is usually through real-time PCR, and we can target these genes by means of these mutations. The ALK biomarker, if found positive, in such cases, crizotinib, ceritinib, alectinib, brigatinib, and lorlatinib can be used. Similarly, there are specific targets which include the same in case of ROS1 and MET, so predominantly the RNA-based ones. And then there are certain other drugs like dabrafenib and trametinib in BRAF, trastuzumab, positinib, and tarloxtinib in ERB2, sotorasib and adagrasib in KRAS, amongst the others in NTRK and RED. For people who are postgraduates, who are studying for their examination, this table is a very good table that gives you a very good glimpse of the biomarker, the associated drug, and the testing modality all in one slide. And you can take a screenshot of the same. Let's talk about these individual ones quickly. The first ones are the EGFR. Now, the EGFR mutations are seen in almost 1/3 of the Asians. As I said, they are DNA-based alterations, which may include mutations, which may include single nucleotide variations, insertions, and deletions. It's more common in female individuals, in non-smokers, and those with adenocarcinoma histology. However, if you do not have a non-smoker female with adenocarcinoma, that does not mean that you should not test for EGFR mutation. 90% of EGFR mutations involve deletions in exon 19 of the gene. And as I said here, TKIs or tyrosine kinase inhibitors such as gefitinib, erlotinib, afatinib, and osimertinib are the treatment of choice. The second mutation is the BRAF. Here, the activating mutations are seen in 2 to 8% of non-small cell lung cancer cases only. And sometimes this mutation can arise as a result of a resistance mechanism to other targeted TKIs in a non-small cell lung cancer patient. Here, in a particular mutation called the PV600E mutation, two new drugs, defrafinib and trametinib, are recommended. The MET is a receptor tyrosine kinase. So here also TKIs or tyrosine kinase inhibitors should show a response. This response is to the tune of 32 to 68% and usually include drugs like crizotinib, capmatinib, tepotinib, and savolitinib. And these are mostly in the form of either gene amplification or mutations involving the splice site or missense variations. KRAS involves 30% of cases of non-small cell lung cancer. Here also, most of the mutations are in the exons 2 and 4. These are also more common in female young individuals, but there is no very specific association. The drug that has been approved recently for KRAS mutations is sotorasib, and it's after a particular test for this mutation. The other mutations include the HER2-neu or the ERB2 mutations. These exon insertions are most commonly seen in lung adenocarcinoma. They're also targeted using drugs like tarloxetinib and trastuzumab along with pyrotinib. And a lot of these drugs are also in clinical trial status as of now. Coming to the RNA-based alterations, they include fusions like the ALK, and these again are more in young non-smoker individuals with adenocarcinoma. Here also, crizotinib is the first ALK TKI which has been approved for these cases, and there are second generation ones like certinib and alectinib that are now also approved. Among the three other gene mutations include ROS1 as a biomarker, which is again in young non-smokers, lot of Asians. The RET, which is in very less percentage of 1 to 2% of non-small cell lung cancer, where selpercatinib is specifically indicated, and the NTRK, which is an emerging biomarker for NRG fusion, which is again activated through HER2, HER3 signaling. And here also there is a response to drugs like afatinib. Of note is also two other tests that are performed in a lot of lung cancer, non-small cell lung cancer patients. One is a PD-L1 expression. PDL1 stands for programmed death ligand 1, and it is a protein that can be expressed on the surface of the cancer cells and other cells in a tumor microenvironment. So what happens is that this expression with the PD1 receptor in the immune cell is like a shield that helps the cancer cells to evade detection. So if they have this PDL1 protein through that receptor attached on the cancer cell, they have a natural shield through which they will not be destroyed by a body's immune system. So we typically measure it by immunohistochemistry staining of the tumor tissue, and we look for those tumor cells that are expressing this PDL1. So if there is a tumor which is expressing a high PDL1, which is 50% or greater, then you can add targeted immunotherapy to PDL1. However, there are also reports that even with a lower PDL1 expression, there could be some benefit to treatment, especially combination treatment. So it's a very, very valuable predictive biomarker. And the guidelines, NCCN guidelines, have also asked for an upfront testing of the PDL1 expression before first line immunotherapy, regardless of the histology, when your patient has an advanced or metastatic non-small cell lung cancer. And these treatments will offer targeting the PDL1 pathway. And if you are able to have this expression and you can target it, you'll have better response to immunotherapy. Other factors like the specific type of lung cancer, the presence of genetic mutations, the overall immune landscape of the tumor can also influence this treatment option. And but it's also important to remember that while this is a very, very important biomarker, it's not the only factor. There are more of such biomarkers like TMB or tumor mutational burden. Then there are specific genetic alterations, which also tell us about the prognosis with treatment. Another concept that you will come across when you read about lung cancer treatment is of immune checkpoint inhibitors. Now, immune checkpoint inhibitors are, they work by blocking those proteins which are called checkpoint proteins that act as an off switch for the immune system. So, whenever there is a blockage of such checkpoints, it prevents T cells from attacking the cancer cells. So, basically, the checkpoint is off, and now the immune system cannot go and attack the cancer cells. So, by blocking these checkpoints, the immune checkpoint inhibitors then allow T cells to effectively target and destroy the cancer cells, because if there is the checkpoint, then the immune system will not be able to attack the cells. Again, the checkpoints prevent the immune system from attacking healthy cells because they turn off these T cells when they're activated. So, this way, it's important if you could estimate the immune checkpoint inhibitors, and you can use them if there are no other actionable molecular biomarkers. You can see this in this image, which is not from these guideline papers, but I've sourced it otherwise, that shows that the PDL1 is binding to PD1 and inhibiting the T cell mediated killing of the tumor cell. So this is the tumor cell in yellow, and this is the T cell. And when the PD1 is bound, here there is a protective shield. And what's happening here again is that there is now a blockage of the PDL1 that allows this T cell now to go and kill the cell. So just like PDL1 expression is helping us, similarly, the immune checkpoint inhibitors can help us. What is the trick of the cancer cells? They exploit these checkpoints. They use these checkpoints, they produce proteins that bind to these checkpoints and turn them off so the immune system cannot see that cell. But when you use these immune checkpoint inhibitors, you can actually make them more visible to the immune system. Now, this is a detailed flowchart from Oncology Reviews from this paper that I discussed, which talks about again the right testing for the biomarker. So, if we choose an NGS test for a patient who has a biopsy proven malignancy and we have done the biopsy, we have an adequate tissue, we can actually check it for NGS if it's possible, if it's available. If you get a known target, you would want to target it. But if you don't have a known target, again, the NGS will help you. And if the biopsy is inadequate, that's also a time when NGS can help you. And you can give some targeted therapy with available medications available. So the panel recommends medicines like crizotinib, entrectinib as preferred first-line treatment options in certain metastatic cancers, and the NGS is also helping us to identify the profile and what treatment can be given. So quickly, I'm going to show you certain flowcharts. They look very, very exhaustive, but basically what you have to understand is that what is the first line recommended therapy. So this figure talks about the exon 19 deletion and mutation in EGFR. So for EGFR mutations, which are discovered prior to first line systemic therapy, you can start on osimertinib, which is a category 1 drug, or you can add that along with the regular treatment, which includes cisplatin, carboplatin, or pemetrexed. Or you could also add certain newer TKIs like erlotinib, afatinib, and you can have some combinations. Now, if you are discovering this mutation during the first line systemic therapy, you can either complete the planned systemic therapy or you can just add them midway also. Both are allowed by the guidelines. Now, in the second flow chart here, you are seeing other mutations other than the exon deletion. And here again, the preferred drug changes a little. It could be afatinib or osimertinib, and then there could be combinations. The same thing applies that if you're seeing this mutation during first-line systemic therapy, you can complete the planned systemic treatment or just add them right away. This tells us what to do if there's a progression on osimertinib. So basically what I want you to understand is that if there's a progression on one drug and your patient is asymptomatic, you see how you can give local therapy, can you give some brachytherapy, can you do a localized surgery for a limited lesion and continue the therapy. But if the patient is symptomatic, there is metastasis or progression, then you have to again consider other options. You have to consider local radiation therapies. You have to consider definitive surgeries, and you can add other drugs, which include amivantamab, which is used along with carboplatin when you have multiple systemic metastasis, and continue the systemic therapy. So a little complex though, but for those who will use it on a regular basis for practice, they need to know this in details. Now here again, you can see what happens when a patient progresses on erlotinib or bevacizumab or gefitinib. In such case, again, you have to rule out whether it's asymptomatic or symptomatic, is there brain metastasis or limited systemic metastasis, and then you can give a combined therapy or you should consider definitive local therapy or surgical intervention. This is about KRAS mutation. Here, the first line treatment is you have to look for PDL1 expression, and you could give sotorasib, adagrasib, and other therapeutic regimens. This is the ALK rearrangement, and here again, other than gefitinib, we have other options, the alectinib, brigatinib, which can be given. And in patients with progression on these, again, we have to see whether the patient is symptomatic or asymptomatic, whether there is brain mets or others, and then a definitive local therapy or a surgery or a brachytherapy along with combinations can be given. Lastly, if your patient has advanced lung cancer or metastatic lung cancer, this table tells us how we need to establish a histology with the tissue. You have to integrate palliative care right ahead. And based on the histology, if your patient has an adenocarcinoma or large cell or other non-specified non-small cell lung cancer, you do the molecular biomarker testing, and based on that, you give the treatment and you do PDL1 expression testing upfront. If your patient has a squamous cell carcinoma, then also your molecular testing includes most of these biomarkers along with PDL1 testing. So, with that, I hope that you're able to get a glimpse of how lung cancer is managed in the current era. There are a lot of specifics and details about it that I have purposefully omitted because it makes the subject more complicated. I hope you liked this video and understood the overall management of non-small cell lung cancer based on the recent guidelines. There is a separate NCCN guideline for small cell lung cancer as well. And if you're interested in me making a video on that, then I can definitely review that article too. Till then, keep tuned, stay tuned, keep subscribing, liking, and sharing Pulmonology Read Aloud. Do mention the other topics you want me to address in the comment box, and I shall meet you soon at some of the pulmonology conferences. So happy reading and take care.